Hi guys, so today we are going to get into the last parts of this book, okay? It's the DSM-5 updated version of Abnormal Psychology, and it's Clinical Perspectives and Psychological Disorders, and it's the 7th edition. And I've been waiting to get into the end of this book because it talks about basically all personality disorders. The reason I want to get into this part of the chapter is because having dissociative identity disorder somewhat twists into all personality disorder features. And the reason I say that is because alternative states of the mind show different somatic symptoms, different emotions, different, you name it. So let's get into it. In this chapter, our focus shifts to the set of disorders that represent long-standing patterns of impairments in an individual's self-understanding, ways of relating to others, and personality traits. As we discussed in Chapter 4, a personality trait is an enduring pattern of perceiving, relating to, and thinking about the environment and others. A pattern that characterizes the majority of a person's interactions and experiences. Most people are able to draw upon their personality traits in a flexible manner, adjusting their responses to the needs of the situation. However, when people become rigidly fixed on one particular trait or set of traits, they may place themselves at risk for developing a personality disorder. Now, DID has faults in perception and unhealthy the triangle of needs are not met with DID, okay? So basically, you grow up learning things that are abnormal, which causes abnormal behavior, abnormal emotions, irregular issues, And in this chapter, we're going to bring up cluster A, B, and C, okay? Here it states, when does a personality trait become a disorder, okay? What may be a characteristic way of responding can develop into a fixed pattern that impairs a person's inability to function satisfactorily, okay? At what point does their unhappiness with the change in order of your possessions become so problematic that you have crossed over from a little finicky to having a personality disorder involving extreme rigidity? Should this behavior pattern place you in a diagnostic category with a distinct set of criteria that separates you from people with other personality traits and related behaviors? And that's what we're going to get into, because it is vital that you kind of understand why there is so many people misdiagnosed with this disorder. But this book is going to give you an idea of why those categories are so vitally assessed. So here you see a definition of what the difference is between personality disorders and dissociative disorders, and they're both distinct conditions. Basically, they both show different patterns and behaviors, but keep in mind they do co-occur together. So that is why I'm kind of doing this video, because symptoms from personality disorders can also be in dissociative disorders. And keep that in mind as I read and stuff, that I'm not saying that DID is a personality disorder, but that the symptoms that come with these personality disorders can be in someone with dissociative identity disorder. Keep in mind, I'm not a professional. I'm just stating what I know and the research and up-to-date research that explains this definition. So next, let's get into these categories, shall we? Fitting the general definition of a psychological disorder, a personality disorder deviates markedly from the individual's culture and leads to distress or impairment. The types of behavior that these disorders represent can involve, or for example, excessive dependency. So you remember me talking about those enmeshment issues. Overwhelming fear of intimacy. So a lot of people that have DID have struggled with relationships, intimacy, things like that. Intense worry, exploitative behavior, or uncontrollable rage. These behavior patterns to fit the diagnostic criteria must manifest themselves in at least 2 of these 4 areas, okay? 1, cognition. 2, affectively. 3, interpersonal functioning. And 4, impulse control. Sorry, sometimes my head is speaking and my lips don't get out what they need to get out. As a result of these behaviors, the individual experiences distress or impairment. Now, what they're going to get into next is cluster A, B, and C, okay? And if you notice this here and this here, please feel free to look at them. They're going to explain a lot of things that we're talking about, and these are images out of the book that I'm reading here. Cluster A includes paranoid, schizoid, and schizotypical personality disorders, which share features involving odd and eccentric behavior. Cluster B includes antisocial, borderline, histrionic, and narcissistic personality disorders, which share overdramatic, emotional, and erratic or unpredictable attitudes and behaviors. Okay? Now keep in mind, these clusters also have symptoms that do relate to DID in different ways. Hence, your personalities may have some of these categories. Okay. Cluster C includes avoidant, dependent, and obsessive-compulsive personality disorders, which share anxious and fearful behaviors. These clusters are not based on empirical data, as the DSM-5 authors point out. They are perhaps best thought of as a rough categorization system, possibly of use in some clinical and educational settings. Because the personality disorders fall into separate categories, clinicians evaluate individuals for a possible diagnosis, must decide how many of the criteria a client meets within each category, and assign a diagnosis on that basis. So that's why it's vital that you have somebody that specializes in DID, because you can be diagnosed with one of these other personality disorders. And a lot of people that have DID are, because the alternative states of your mind can give different impressions, okay? At one time, researchers proposed eliminating the categories entirely and replacing them with dimensional ratings, such as scales based on the 5-factor model. Nevertheless, the categories seemed to hold worth, and as long as the researchers could delineate distinct imperial-based criteria, the DSM-5 authors proposed a possible compromise. They revamped the original 12 personality disorders, 11 categories plus, not otherwise specified, into 6 plus an additional category for individuals who did not fit into the 6. Within each personality disorder, the authors set imperial-based criteria, Livesley, 2011, along the dimensions of self and interpersonal relationships. This dimensional system is shown in Table 14.1. In addition, in this framework, clinicians would have evaluated all clients on the consistent sets of 5 personality traits. In the end, they decided that the dimensional system would move to Section 3, where it would receive further study, and then in the future, the issue would be revisited. So they're basically talking about how they want to make everything factual and legit, and there was a lot of studies done to do this process, and these charts are an example of what that is. So next, let's get into Cluster A, Cluster B, and Cluster C, okay? These are going to give a definition on what's in the DSM-5. Cluster A of the personality disorders in the DSM-5 include those disorders categorized by eccentric behavior. In other words, individuals with these disorders show characteristics that might lead others to view them as slightly odd, unusual, and peculiar. Paranoid personality disorder is one of them in this category. People with paranoid personality disorder are extremely suspicious of others and are always on guard against potential danger or harm. Their view of the world is very narrowly focused. In that, they seek to confirm their expectations that others will take advantage of them, making it virtually impossible for them to trust even their friends or associates. They are unable to take responsibility for their mistakes and instead project blame on others. If others criticize them, they become hostile. They are also prone to misconstrue innocent comments and minor events as having a hidden or threatening meaning. They may hold grudges for years based on real or imagined slight by another person. Although individuals with this disorder may be relatively successful in certain kind of jobs requiring heightened vigilance, their emotional life tends to be isolated and constrained. Okay, number 2 in this category, schizoid personality disorder. An indifference to social and sexual relationships categorizes schizoid personality disorder as well as very limited range of emotional experience and expression. Individuals with this disorder prefer to be by themselves rather than with others, and they appear to lack any desire for acceptance or love, even by their families. All right, number 3, schizotypical personality disorder. Confusions and distortions in the individual's basic sense of self are a core feature of schizotypical personality disorder. Such individuals lack a clear sense of direction, motivation, and do not have a clear set of standards against which to measure their behavior. Not only do they have difficulty understanding their own sense of self and motivation, but people with schizotypical personality disorder also have difficulty understanding the motives and behaviors of others. So what they're speaking of here is 3 definitions in the cluster A category. And if you notice, there are some things that I'm like, you're going to go, I have some of that, okay? Keep in mind, each alternative state of your mind with DID can show displays of some of these disorders, which can confuse somebody that's not professionally trained in DID, which could make you think that you might have one of these 3 categories, and you might not. Or you may think you may have DID, and you don't. That's why it is so vital that assessments be done very carefully. Okay. Next is the cluster B category, and cluster B personality disorders include those that are marked by dramatic, emotional, or erratic behaviors. These behaviors include impulsivity, an inflated or apparently inflated sense of self, and tendency to seek stimulation. Okay, there's 4 categories in this one. One is antisocial personality disorder. Okay. And antisocial personality disorder is highly impulsive and lacking in the capacity for regret over their actions. Another thing it states, the antisocial lifestyle trait revolves around impulsivity and characteristic that can lead to behaviors expressed in unstable lifestyle, juvenile delinquency, earlier behavioral problems, lack of realistic long-term goals, and need for constant stimulation. Family inheritance studies provide strong evidence in favor of genetic explanations of antisocial personality disorder. The personality trait of sociopathy and antisocial behavior with heritability is states as high as 80%. To explain this genetic variation, their attention is focused on genes related to the activity of serotonin and dopamine. One in particular is monoamine oxidase A, an enzyme, and I may have said that wrong, coded by MAOA gene. A mutation in the gene results in insufficient amounts of monoamine oxidase in the nervous system, which results in abnormal high levels of dopamine, serotonin, and norepinephrine. High levels of neurotransmitter. These neurotransmitters are linked to greater impulsivity. Okay, so how's that have to do with DID? Well, DID is not genetic. DID is created by severe childhood trauma, abuse, sexual and physical. Okay. So this is something that can take out this diagnosis. If they happen to give it to you, they can see that there's no genetic factors in it. So that helps. So I hope you get that's why it's so vital to assess everything thoroughly. Next is borderline personality disorder, which you all know is something that quite a few people who have DID have been diagnosed prior with this issue. Okay. The term borderline is in this personality disorder relates to its origins in the 1930s as a condition on the border between neurotic and psychotic forms of psychology. On the edge of schizophrenia, the criteria are very different now than they were at the time, reflecting continuing reversions of the criteria of this disorder, but the terminology remains with us today. Okay. Characteristics of borderline personality disorder. Borderline personality disorder rests on the individual's demonstration of at least 5 out of the possible 9 behaviors, including frantic efforts to avoid abandonment, unstable and intense relationships, identity disturbance, impulsivity in areas such as sexuality, spending, or reckless driving, recurrent suicidal behavior, affective instability, chronic feelings of emptiness, difficulty controlling anger, and occasional feelings of paranoia or dissociative symptoms. In the dimensional rating system in Section 3, clinicians will evaluate individuals along the dimensions of personality and interpersonal functioning, as well as on the extent to which they show negative personality traits. Okay? Now, keep in mind when you're looking at this chart, because it explains a lot of things that are not talked about. Okay? Now, I was diagnosed with BPD for a little while, but I did not meet 3 out of the 5 categories. So they couldn't figure out what I had. And then it all of a sudden showed up when I was in inpatient care in 2017. Okay, and they already knew I had on my disability chart, which is shown in a prior video, that I had a dissociative disorder. It was put already down in there in 2009. The issue was they couldn't quite figure out what it was. So it was basically, they put on the chart dissociative disorder with complex post-traumatic stress disorder. So, unfortunately for these individuals, the more that they seek the reassurance and closeness of others, the more they drive these people away. As a result, their disturbed feelings only become more intense, and they become more and more demanding, moody, and reckless. In this way, the symptoms of the disorder become cyclical and self-perpetuating, often escalating to the point of which the individual requires hospitalization. Okay, so next is histrionic personality disorder and narcissistic personality disorder. Clinicians diagnose histrionic personality disorder in people who show extreme pleasure as the center of attention and who behave in whatever way necessary to ensure that this happens. They are excessively concerned with their physical appearance, often trying to draw attention to themselves in such extreme ways that their behavior seems ludicrous. Furthermore, people perceive them as flirtatious and seductive, and they demand reassurance, praise, and approval of others and become furious if they don't get it. They want immediate gratification of their wishes and overreact to even minor actions, usually in exaggerated ways, such as by weeping or fainting. Although their relationships are superficial, they assume them to be intimate and refer to acquaintances as dear friends. They are easily influenced by others, lack analytical ability, and see the world in broad impressionistic terms. Okay. And in this photo here, this talks about, or shows more or less, narcissistic personality disorder. Now keep in mind, some alternative states can show somatic symptoms of these perceived personalities. Okay. People who meet the criteria for the diagnosis of narcissistic personality disorder, NPD, base their self-esteem excessively on the views of other people. They see themselves as exceptional and have a strong sense of entitlement. Because they see themselves as exceptional, they may set their personal standards as unrealistically high. Conversely, they may regard themselves as entitled to whatever they want and therefore set their personal standards far too low. Their impairments in goal setting also include a constant attempt to gain approval from other people. Now last is the cluster C personality disorders. Number 1 is avoidant personality disorder. People with avoidant personality disorder define themselves as lacking in social skills and having no desirable qualities that would make others want to be with them. They are more than shy. Instead, their feelings of shame and inadequacy are so strong that they prefer not to be around others. They stay away almost entirely from social encounters and are especially likely to avoid any situation with the potential for them to feel embarrassed. They may set unrealistic high standards for themselves, which in turn lead them to avoid encountering situations in which they feel doomed to fail. Now, again, I've had issues with avoidancy. I also have issues with relationships. So, do I have this? No. According to the assessments that have been done, I do suffer from agoraphobic issues, but not this. Next is dependent personality disorder. Okay. Individuals with dependent personality disorder are strongly drawn to others. However, they are so clinging and passive that they may achieve the opposite of their desires as others become impatient with their lack of autonomy. Convinced of their inadequacy, they cannot make even the most trivial decisions on their own. Others may characterize individuals with this disorder as clingy. When they are alone, people with dependent personality disorder feel despondent and abandoned. They become preoccupied with the fear that close ones will leave them. They cannot initiate new activities on their own because they feel that they will make mistakes unless others guide their actions. People with obsessive compulsive personality disorder, also known as OCPD, define their sense of self and self-worth in terms of their work productivity. We have just seen that people with MPD may also become excessively oriented towards work accomplishments to bolster their sense of self. People with OCPD are not looking for approval from their work accomplishments. It's going to be one of them days today. But instead throw themselves into their work to the exclusion of their social relationships. Unfortunately, the extreme perfectionism that people with OCPD have about their work makes it difficult for them to complete a task because they can always see a flaw in what they have done. Their work products are never good enough to meet their unrealistic standards. They can also be overly moralistic because they stick to overly conscientious standards that almost anyone would find difficult to meet. So last on this, before I give you the references and things like that, we're going to get into 14.5, which is the personality disorders, the biophysiopsychosocial perspective. The personality disorders represented a fascinating mix of long-term standing personal dispositions and behavior patterns and disturbances in identity and interpersonal relationships. Although we tend to focus on these disorders as they appear at one point in time, clearly they evolve over an individual's life. Okay? The DSM authors will very likely continue to refine and elaborate on their scientific base, if not their classification. We may hope that mental health professionals will develop not only a better understanding of this form of disturbance, but also perhaps a richer appreciation for the factors that contribute to normal personality growth and change through life. So last, you are going to see the ethic standards of the APA, which is here, and then you are going to see here the guidelines for assessment of intervention with persons with disabilities, okay? And the reason I want to touch basis on that is because this is very important that people meet these standards, because it can ruin your healing process, okay? Ethical standards. To be considered a psychologist, many states require that an individual pass a rigid set of licensed requirements. All states in the United States have a board of psychologists that carry out the legal requirements for obtaining and retaining a psychological license. These requirements typically include passing an examination, obtaining a certain number of hours of supervised training. I'm going to stop there a minute because I want to talk about that real quick. My therapist allows some students to come in to earn their clinical hours. Basically, that is a part of the criteria to get your degree. Colin Ross also allows students to come in and to earn their clinical hours and earn time and learn about DID, BPD, trauma, basically, people that have complex post-traumatic stress disorder. Receiving recommendations from other licensed psychologists and to remain licensed. Participation in a certain number of hours of continuing education. Okay, and in this table you will see that there are resolving ethnical issues, competence, human relations, privacy and confidentiality, which there are lots of different boundaries that you have to follow when you are a therapist or psychologist. Advising and other public statements. You have to post your license publicly to let people know that you have been renewed and whatnot. I don't know the whole jumble mumble about that, but check it out, okay? Record keeping and fees, education and training, research and publication, assessment and therapy. And these are basics, that these people go through. These people work so hard to get a degree and to learn all these things to help you, okay? Now, on this side, you will see the guidelines for assessment of the intervention with persons with disabilities. And there's a lot of guidelines to be met. Disability awareness, training, accessibility, and diversity. These are things that you learn about when you are in college to get a master's or a bachelor's, testing and assessments. You need to learn about the tests, up-to-date resources, connecting with other therapists or psychologists to meet your needs, and how to learn certain boundaries, because you are going to get people with DID that will push you above and beyond for those issues. And interventions, of course. People that need help with that. It's vitally important. Basically, psychologists strive to be aware of therapeutic structure and environments impacting on their work and clients with disabilities. So if there's a client that's blind, a client that has alternative states such as a little that comes into play, and not literally come into play, but just hypothetically, like if somebody brings in somebody that has DID and all of a sudden there's a switch that takes place because of the stress and a smaller alternative state is out, sometimes a therapist or psychologist has to help that individual to either get out of that situation or to be patient enough to work with that alternative state till the host comes back, etc. So anyway, the last of this video is going to give you some references and show you a bit of the back of this book here. And we are done with this book. It was definitely worth the read. There was a lot in it, and I very much enjoyed it. So if you can get it and you want to learn more about the abnormal psychology behind basically the perspective of psychological disorders or abnormal disorders, this book was definitely worth it. So, yeah. And here's the ending of that book. This is the glossary of terms. You're welcome to screenshot anything that you want to know, but this is pretty much it for this chapter, or well, basically this book. It's got a lot of definition. They got DID in here and dissociative amnesia and everything, depressants. If you're willing to learn, you can read all this stuff and then some. I'm not going to go through the whole thing, but you can definitely see, they got post-traumatic stress disorder in here, PCP. This whole book is filled with a glossary of terms on what's, the references. Here's all the references from the American Psychological Association, the doctors that they've worked with, etc. This is a college level book, and it helps to give an understanding of, different personality disorders and why they collide together. So as you can see, there's the whole reference with this book, and then you get into the credits for the photos and things like that. And so yeah, so this is the name category and things like that. So yeah, that's it for this book, guys, and I found it very useful, and it's, like I said, the up-to-date DSM-5 version. This helps not only you and me to understand a lot of things that the doctors are trying to explain, but also to help towards a diagnosis. So I hope you found this video useful, and that's all I have today.